Thank you, Rebecca, for the opportunity and, of course, devising this wonderful course. Uh, so she gave me to talk on unanswered questions. Now, I mean, assuming as if I knew answers to the unanswered questions, then I'm sure they would not have been listed as unanswered. But anyway, uh, please, the slide if possible, please. Yes, Rohit, the one that is highlighted. Yes, great. Um, so, thank you. So, a lot of unanswered questions, and frankly, I don't think we still have the answers to them. So, I'm just kind of throwing them, and I'll give you some of the ideas which we have or what the collective wisdom at the moment in literature is there. And of course, I'll be open to opinions and updates and information from everybody here, knowing that now everybody has to practice management of myopia in children, just like cataract. I think the next most important thing that we'll be dealing with as time goes on is myopia. So all of us need to be aware about it, and all of us would have their own different ways in managing it, just like all of us have different techniques in cataract. So similarly, all of us would have our experiences in managing myopia in a child, because uh, that's what we are gaining and our understanding is going. So first thing, why does it occur? Now there is a very clear evidence that it is changes due to lifestyle. In fact, now last few months I've actually stuck my neck out and I'm going everywhere aware, and I believe this strongly, that myopia in children is the youngest lifestyle disease in humans. Over the last 30 to 40 years, across genetic makeup, across races, the magnitude of myopia has significantly increased. And obviously, genes don't change in 40 years. It's clearly the environment or the environmental influences on the genetic makeup that has made this happen. In fact, there is a very interesting study from Singapore which showed that the first generation immigrants from India to Singapore had about the myopia prevalence of 12 to 14%. And the second generation, their children there, it jumped to about 24 to 28%, showing the impact of environment on the same pool of genes. So there is no doubt that whether individually or in association with a lot of other factors, some of which was discussed, like vitamin D, uh, our behaviors, stress. So all these things, how much they have, but lifestyle definitely has a change. As I mentioned, some genetic groups are more susceptible, whether it is because they have incorporated the environment much earlier. We know that Asian children are very, very pressed to be high performers. So is it because of that very, very stressful environment they are in from the very beginning? And that has been sure, that has been seen in the last 40, 50 years, particularly in the East Asia part of the world. Although I don't think India was bereft of this, but thankfully we still have a lower percentage of myopic children. But there could be that some genetic races are more susceptible as compared to others, but all of us, irrespective of race, are affected. So I talked about the Singapore study. So again, back to, definitely environment has a huge role to play. We are still understanding the role of light, nutrition, like I said, the stress levels or whatever we are eating or breathing. So we are not sure what all makes a difference, but definitely environment, and particularly we've talked about the distances of reading, our lack of going outdoors. All these are major factors that are changing, and that's where all the research is going on. As I mentioned, I think youngest lifestyle disease in humans is myopia. The next question comes, how does atropine work? That's been on the back of our minds for a long time. And I mean, I really understood the word serendipity with the vaccines, when they told us how they actually stumbled upon the dose of vaccine for COVID. But really, it was serendipity that we came to low dose atropine. Zero point zero 0.01 was actually the placebo in the atom study. The basic concept going in pharmacological therapy is that if you 100 times dilute what is a known effective dose, you can use that as a placebo instead of a vehicle. So they thought that 1% works. So 0.01%, 100 times the dilution, is an ideal placebo. And serendipity, they came out that low dose atropine or 0.01 was very good. I won't say the best. If you read the study and if you read all the literature that is available, and you kind of crystallize it or distill it into understanding, low atropine has a dose dependent effect on progression of myopia. Why we like low dose atropine? Because of its minimal or negligible side effects, as also the rebound that they realized was more higher the dose. So finally, when you stopped it, the most effective drug or most effective concentration was 0.01. This could, as Dr. Rebecca was talking about, this may be different in different races. There is an ongoing trial in India on 0.01 versus 0.05, and let's see how the efficacy of 0.05 is. We expect it to be better, but obviously we know that the side effects are more. So maybe every race will have to come out with its preferred concentration levels. And till the time we're able to understand that, each decision or concentration on a child has to be an individual based understanding or information. So at the moment, there is clear lack of evidence how it works. There is a lot of concept that it works by acting on the posterior segment, on the retina, on the choroid. This was a question that actually hounded me, and this was something we thought that actually I wanted to disprove. I thought it can't, 0.01 can't reach the vitreous. So why are we saying that it's going to affect the retina, choroid, sclera, and maybe the cortex also? So we did this study. It was an interesting study, and hopefully we'll get it published soon. We did 1 drop of low dose atropine and got vitreous and aqueous samples, very ethically, of course, prior to cataract surgery. 1 drop of low dose atropine, and an hour later, when we did the cataract surgery, we did the aqueous tab. And similarly, before vitreous surgery, an hour, 2 hours, 6 hours, when just before doing vitreous surgery, of course, for some other indication, cataract surgery for a patient with cataract, vitreous surgery for a vitreous hemorrhage or something. Not the ideal environment, but we were able to get measurable levels of atropine in the aqueous and vitreous within 1 hour of the drop. So it reaches where we are saying it is supposed to work. Now again, the fact that it reaches the vitreous does not prove that it works in the posterior segment. But as I said, that was an interesting thing that we actually have observed. So probably it is acting on the posterior segment. But we also find clear evidence that it works in the anterior segment, and that is a no-brainer. Atropine is a cycloplegic. Whatever the dose level, its primary aim is to cause cycloplegia, and it definitely does that even in the low dose levels of 0.01. Again, another publication we actually hopefully will again come in sprint soon. We evaluated the change in the lens power by doing progressive biometries in these children who were on low dose atropine pre and after their treatment, and we found a significant measurable change in the lens power on atropine. So there's always been that, the criticizers of atropine have always said that why is there this disconnect between the effect on refractive error versus its effect on axial length? Why is there no good correlation between the two? So one of the possible answers, and everybody speculates, that is possibly the anterior segment change. So atropine must be working, there is no doubt about it. But low dose atropine or any dose of atropine partially works by causing cycloplegia also. And maybe that is why the rebound, when you stop it, obviously the power comes back, and what you call as rebound is probably recovery of the accommodational tonus of the ciliary body, and therefore it works, but not as great as we think it does. Again, these are, as I said, this is all under the discussion of unanswered questions. I'm not saying that anybody asked here has the answers, but possibly. So this is the question: why the disconnect among low dose atropine, possibly the anterior segment changes, loss in the crystalline lens power, and as I mentioned, possible cause of some rebound. Is peripheral refraction mandatory workup in myopia now? When we are talking that the concept of these spectacles is peripheral hyperopia, and our lenses are designed to prevent or overcome that by creating mid-peripheral myopia, is this necessary now? At the moment, there is no evidence that you need to have peripheral hyperopia for these spectacle lenses to be effective. So at the moment, all types of refractive errors have been found to be manageable or managed by these lenses. The Hoya, the SLR studies have not shown any difference in the result with relationship to peripheral refractive errors. And therefore, at the moment, I would say it is not an essential component. It does not decide the way you're going to manage or what you're going to do. So there is no evidence that spectacles with peripheral ad are helpful only or significantly in children with peripheral hyperopic. And what do we do with if the child is still progressing on treatment? Again, most important workup for treating myopic progression is baseline, or the amount or magnitude of refractive error change prior to your intervention. You must know how much the child is progressing before you start treating what you have to treat, what you identify as disorder. Just because a child has come to me with refractive error and has a moderate myopia, and I do not know how it was 1 year ago, is not the indication of starting treatment for preventing myopia progression. The child has myopia today, you have to prove he has progressive myopia and then start treatment. So you must know the rate of baseline refractive error change or rate of myopia progression before you start treatment. It's like, you need to know there is glaucoma before you start giving anti-glaucoma medication. It is must. Because it will tell me whether I am treating effectively or not. If I do not know baseline IOP, how do I know my drug that I have given blindly is working or not? Today the patient's pressure is 24. I don't know it is from 30 or from 25. So the drug I'm giving, is it effective, or I'm just increasing the side effects? So when I know the rate of baseline myopic progression, I start treatment A. I observe it 6 months. If the rate of myopia progression has reduced, I know it is working. Now, whether it's working satisfactorily or as much as I want is the second part of the question. But the first part, the drug, yes, is working. He was progressing at, say, 1 diopter. Today, he's 0.5 diopters. Now, 0.5 is also high. I supplement because I know the drug is working. But if there is very little effect, he was progressing at 1 and he's changed by 0.75, I may think in terms of substituting. So we know additive therapy of optical and pharmaceutical work. So that is how I'm going to decide. Why treat everything simultaneously in all children? You don't give all the available anti-glaucoma medication to every child, every patient of glaucoma who comes. You choose, you identify the most appropriate therapy, you follow up. So same rules we should use for a long-term chronic 2 years or more therapy. The most important question, when do we stop treatment? If I start anti-glaucoma medication in a younger child, clear evidence, younger the child, the faster the rate of progression, the higher the baseline refractive error, more the child is going to progress. I'm going to continue for 3 to 5 years, which is the evidence of treatment at the moment available, because I know these children have the tendency to progress till 15, 16 years of age. If I pick up a child more than 10 years of age, these are my arbitrary decision tree. It's not based on fact or science, it's based on experience and what I feel should be. So if it's an older child with lower baseline myopia, I may treat for 2 years, stop and look for rebound. Of course, never stop standard, just do a small taper over 6 months and then follow up the child and see. If it rebounds, if you see again a progression, restart. So that's how we have to have evidence. How to choose what to take, opticals, pharmaceuticals, there is no clear evidence at the moment on anything whatsoever. So I would say the most important thing is factored in is should be economic, whether the parents can afford it, because we can't force them to buy something which we are still finding evidence on. Essentially poor ocular surface, obviously no contact lenses. High myopia, high astigmatism, atropine only because spectacles, contact lenses not available. Child has decreased near vision, accommodative lag. It's important to check that, because earlier we used to think myopes won't have accommodative lag, but they do. So in them, be a little wary of starting atropine. And of course, like I said, economic constraints are the most important. We're still not sure red light, blue light, because both have shown to be effective. So I don't know which color light is effective. Role of vitamin D has been discussed. Again, whether it's a confounder because of outdoor activity, or there is a kind of role for treating with vitamin D. But, orthopedicians and everybody has told us that 90% of Indians are vitamin D deficient. So it should be a staple diet. So I don't know how much it's true or a confounder. Pre-myope was discussed. I would say that lifestyle changes have shown to have 30 to 40% impact. I would say every child should be encouraged to do lifestyle change, see the impact before you start giving treatment for myopia, because after all, he's a pre-myope. You don't treat pre-glaucoma or glaucoma suspects. So you don't treat pre-myopia, at least in the low prevalence country like India. So it's very, very important that we decide what we are going to do. And finally, questions we don't know answers of. Can we stop myopia progression? We don't know. We cannot stop it completely, but yeah, slow it down. And we still don't know how we are going to answer a lot of questions that we still don't know. Thank you.
Thank you, sir.